Good afternoon, dear colleagues. This is Tom Thijs. Welcome to our second webinar of the ENS functional section, where it's my job to moderate webinars with world-class experts in the field. Today, we will cover brain surgery for psychiatric disorders, as Professor Blomstedt will walk us through the fascinating history of neurosurgery for psychiatric diseases. Professor Blomstedt is professor in stereotactic functional neurosurgery and director of the Stereotactic Academy. He has written over 150 scientific papers and book chapters, and his current research focuses on zona incerta as a target for DBS and DBS for the treatment of psychiatric disorders. Our expert panelists are Professor Veerle Visser van der Wallen, who will join soon, and Professor Bart Nutin, who are both pioneers in the field of DBS for psychiatric disorders. They respectively performed the first cases in Tourette syndrome and OCD. I want you, all of you, to encourage to actively participate by writing your comments and questions in the Q&A box. We will have a discussion on the go, so you can pose questions at any time during the presentation, and I will check this regularly. The discussion will be followed by a short presentation of the Stereotactic Academy, the e-learning platform of Professor Blomstedt that he's developed, and that covers clinical information related to stereotactic functional neurosurgery and DBS. Please, Patrick, take us back in time, please. Thank you.
Thank you, Tom. Let me start by sharing my screen. And perhaps you could tell me if I'm succeeding and if you can actually see my screen.
You are succeeding. Thank you.
Perfect. I'm quite talented, I must say. And I will just move this a little bit out of the way. So, thank you for giving me the opportunity to come here and talk about the history of psychiatric neurosurgery and to provide you with a background for what we are doing today. And I suggest we start already from the beginning. When looking at the archaeological material, it seems as if our ancestors had an almost irresistible desire for making holes in the head of their fellow humans. Trepanations are abundant in many areas around the world and stretches back to the Paleolithic era. But we don't know why these were done. Perhaps the indications were sometimes of a functional nature, like letting out evil spirits causing problems. Here to the right, we see a more modern video of the Kinsi tribe in Kenya performing a trepanation with a stone tool and banana palm wine. If we move from the prehistorical era to historical times, then Galen stated that vapor from black bile in the ventricles can cause epilepsy and melancholy, and Aretaeus the Cappadocian recommended trepanations for epilepsy in order to exhale these fumes. And the first time a trepanation is clearly recommended for a psychiatric indication is in the 12th century in Practica Chirurgiae by Roger of Salerno. Here he writes, for mania or melancholy, a cruciate incision is made in the top of the head and the cranium is penetrated to permit the noxious material to exhale to the outside. In the art from the 15th century and onwards, extraction of the stone of madness was a popular motive, but this is probably a purely allegoric motive. During the following centuries, we will now and then meet trepanations for psychiatric disorders, such as in The Anatomy of Melancholy by Robert Burton from 1621. The development of more modern theories regarding the brain can be said to start with Vesalius in 1543, and we then see a rapid development, especially during the 19th century, with an increasing understanding of the human brain and its function. And modern neurosurgery is born in the end of the 19th century. An early neuropsychiatric procedure was trepanation with opening of the dura and CSF drainage for general paralysis of the insane in neurosyphilis. But the first intracerebral procedure were done by a Swiss psychiatrist, Dr. Gottlieb Burckhardt, in 1891. He operated 6 schizophrenic patients with removal of various cortical areas, chosen quite randomly and with very limited success. The first frontal lobe procedures with cutting of parieto-frontal connections in 3 patients were done in 1910 by Ludwig Puset and Bechterew. The outcome was also poor and not reported until 1937. Sorry. Thus, according to the traditional accounts, nothing happened in the field of psychosurgery during the period between 1891 until the introduction of the lobotomy by Moniz in 1936. But this is not completely true. And if you would like to learn more about this fascinating history, please consult this lecture online or this recently published paper on Maurice Ducoste.
Sorry, Patrick, are you saying that Ducoste should have had the Nobel Prize?
Well, I'm not sure that Moniz should have had it, but if he should, then he should definitely have shared it with Ducoste. And I can point out why. Because this psychiatrist, he was working at the asylum of Villejuif in Paris, and he started already in 1920 to perform mechanical lesions with the steel wire in the frontal lobes in schizophrenics, and later also in patients with mania and depression. And in 1925, he turned to injections. In 1933, he had operated and published not less than 268 cases, and in 1940, 1,000 operated patients. So quite a large experience. And he used to perform a trepanation, a point about 10 centimeters behind the orbital arcade. That is more or less where we do our entry points for DBS today. And he would insert a needle 4.5 centimeters into the frontal lobe. And here, using a special device, he would inject blood or other substances. And he could repeat this up to 12 times in the individual patients. So he must have done quite large frontal lobe lesions. And this also spread to other countries. And his group presented 16 publications on this topic. But unfortunately for him, he met Moniz. And this was at a meeting of the French Academy of Medicine in 1932. And Moniz presented a paper on angiography, and immediately after him, Ducoste presented his cerebral impallidations. And they also appeared together in published form. And here Moniz would have learned that a very large number of patients with various psychiatric conditions, including schizophrenia and mania, had been operated with reportedly favorable results using injections into the frontal lobes, and that it had been done without serious complications. So 3 years later, Moniz performed his first operations with Almeida Lima, and in 1936 he presented the lobotomy in 20 patients and published his papers in 6 different languages, which he sent around the world in order to establish priority. And he was actually using the same entry point, target, depth, injection technique, and indications as Ducoste, who had by then operated more than 500 patients in 5 publications. And the only difference was that Moniz used injections of alcohol and injected both frontal lobes at the same time.
So Patrick, just a short question when it's possible. So I always thought Egas Moniz was a neurologist who didn't operate himself. Is that correct or not?
That is completely correct. If we look here, then we actually see Egas Moniz sitting here and just giving the instructions. He also suffered from arthritis, and he wouldn't have been able to operate. So he had a young neurosurgical colleague, Almeida Lima. Anyhow, Ducoste was a bit upset and started a battle of priority in May 1940, but just 1 week later, Germany invaded France, and after this, we hear no more about Ducoste. And the future development of lobotomy occurred mainly after the war and mainly in USA, where no one had heard about him. And Moniz never acknowledged Ducoste with a single word or a single reference and received the Nobel Prize in 1949. So life is quite tough sometimes. Anyhow, it is today difficult to understand the popularity of this lobotomy, but likewise, it is difficult for us to understand the horrendous state of the psychiatric care before the introduction of antipsychotic drugs in the 50s. Many asylums were overcrowded with severely ill and sometimes uncontrollable patients. And just take USA as an example. Actually, half of all the beds in the healthcare system were occupied by psychiatric patients, and the budget allotted for these patients were seldom enough to provide a dignified existence. So any suggestion on how to improve the conditions would have been welcome. And no possible therapy was too strange to be considered or too dangerous. Insulin coma, ECT, and even extensive colectomies with a high mortality was used. This leucotomy of Moniz, that was a crude and imprecise procedure, and it's very unlikely that it would have become widespread. However, Walter Freeman, working with a young neurosurgeon, James Watts, started performing leucotomies in USA already in 1936. But the effect was poor, so they started to make larger and larger lesions, which resulted in larger and larger side effects. And for that reason, they developed the ventriculography-based standard lobotomy, making the procedure less arbitrary. They did also abandon the leucotome and started to cut frontal connections using a blunt blade. And in this video, we see Freeman directing Watts regarding how to make these incisions. Further, in 1942, he published the monography, Psychosurgery, where Freeman provided a scientific rationale for the procedure, which was essential for a wider acceptance of the lobotomy. And he defined the goal of the lobotomy as to cut the connections between the dorsolateral thalamus and the frontal lobe. And this book resulted in a major surge in the interest for lobotomies. But when speaking about these lobotomies, it's important to realize that a large number of very different procedures were developed and used. This development was driven by a will to improve the effect and reduce side effects. And it was found that this could to some extent be achieved by focusing the lesions in the medial and deeper part of the frontal lobe, overlying the orbita, that is the orbitofrontal cortex. And the most well-known of these procedures was the ice pick lobotomy, or the transorbital lobotomy, first developed by the psychiatrist Mario Fiamberti, but promoted by Walter Freeman, mostly because it could be done by the psychiatrist himself without the need for a neurosurgeon, and he could do up to 25 procedures a day, and some of his disciples would do actually 75 procedures in a single day. And this transorbital lobotomy, as we see here, it looks terrible, but was probably an improvement compared to the standard lobotomy, both concerning the effect and especially concerning complications. When we are looking at the modern literature on the history of psychiatric neurosurgery, it is not unusual that less well-informed writers assume that the most famous persons behind these procedures were neurosurgeons, but in reality, they were most often psychiatrists or neurologists specialized in psychiatric disorders. Here, for example, we see the second most experienced lobotomist after Freeman, that is the Japanese psychiatrist Sadao Hirose. And it's interesting as a sign of the spirit of this period to read from a paper published by Ernulf Ødegård, who was the head of Norway's largest mental institution, who wrote in 1953 that psychosurgery can be easily performed by the psychiatrist himself with the tools he might have in his pocket, and strangely enough, it may be harmless and effective.
Patrick, can I ask another question?
Yes, please.
So we know from the meetings nowadays that there are many neurosurgeons interested in psychosurgery or neurosurgery for psychiatric disorders, but it's relatively hard to get a lot of psychiatrists involved. There are some, but why is it so that so many psychiatrists were interested in that stage and now less? You have an idea?
Yes, I have an idea. I think that this history with lobotomy that was actually driven mainly by the psychiatrists, and where the neurosurgeons had a quite limited role, to be honest. It was a huge trauma for the psychiatrists as a specialty. And I think that today a lot of people are still suffering from that trauma and have turned away from the surgical possibilities. So it will take a major effort to make them give this a second chance, and hopefully with the neurosurgeons more involved.
Could it, Patrick, also be well, a consequence of a more and more connection between the psychiatrists and the pharmaceutical industry, that they are more and more interested in medicine and drug therapies compared to surgical therapies?
Yes, of course. I mean, if you look at psychiatry before 1950, they did not have a lot to offer the patients. And suddenly they get the lobotomy. And to some extent, it worked. So they have something to offer for the first time, more or less. But then they got the first effective medicines, and now they have so much to choose from. Also, we need to be humble and realize that what we are doing is it's very limited. We have some small studies on few patients, and they are today used with huge studies with thousands or even tens of thousands of patients. So we are very peripheral compared to medical therapy in their eyes. So, to continue, as I said, probably the lobotomy was in some patients effective with the standards of those days, even if they were not with today's standard. And also the side effects of the lobotomy were well known even during that era, and we see a development towards more and more selective procedures as we go on. And this includes also stereotactic functional neurosurgery, introduced by Spiegel and Weiss in 1947. And many of you have seen this photo of them performing a procedure in 1948, but few of you have probably read the heading under the photo, New Brain Operation for Mental Illness. They introduced stereotactic functional neurosurgery with the specific intent of reducing the side effects of lobotomy, and they first used it in psychiatric patients. Their target was based on the theories based by Walter Freeman, and as we see here, they were congratulated by him. The most common stereotactic procedures were the cingulotomy, the capsulotomy, and to some extent the tracheotomy. And it's perhaps not difficult to understand how these came into existence if one considers that all of these are located in the plane where a typical standard lobotomy would be performed, as Reese Cosgrove has pointed out. For historical reasons, the cingulotomy were preferred in the USA and the capsulotomy in Europe. These are quite similar. The capsulotomy is perhaps a little bit more effective, but also a little bit more dangerous.
Could we pause here a second? I see that Veerle just arrived. Veerle, welcome. Yes. And also we could maybe discuss, well, could you just go back to the previous slide? Because you show these historical lesioning techniques, of course, cingulotomy, capsulotomy, and tracheotomy. But of course, these techniques still exist nowadays. I don't know if you can comment on this, or you would disencourage your surgeons to go ahead with lesioning, or what is your thought on making lesions in the brain nowadays?
I think that if you are a stereotactic functional neurosurgeon, then you should know how to do it. And I think that for movement disorders, probably DBS is better in most of our patients, but in a few patients, then lesions will be a better alternative. And it's very valuable to know how to do it if you need. Concerning psychiatric neurosurgery, I would say that I definitely think that lesions have a role there. I think that if we take the internal capsule area, then there is nothing suggesting that DBS is more efficient, and it's definitely more easy just to make a small lesion and then you're done with it, instead of having a patient that you need to follow for the rest of his or her life. So, but the problem is how this procedure is perceived. And that's why we in Sweden have, yes.
May I ask you, well, so far you have made no distinction among the various psychiatric disorders that exist and for which perhaps those procedures have been done. Hasn't there been also in old times, in ancient times, be a sort of result for which disorders those procedures were the best and for which not at all indicated?
Yes, and this is a very difficult question. And when you read this literature from that era, a lot was written, a lot was done, and often by very skilled colleagues, but it's not easy to translate this into terms that we understand today in a good manner. If you look at the lobotomy as such, then this seems to be most effective for depression and such. But in reality, it was mainly used in schizophrenics and such conditions because the need to tranquilize this group of patients were larger. But it was recognized that it was not very efficient in these patients. And later on, when we come to the more specialized procedures, such as stereotactic lesions, then quite soon the interest focused on DBS for obsessive compulsive disorder, but also on anxiety and on depression. And I can't say that I'm an expert on the historical data, but I think that the best results were already then presented for obsessive compulsive disorder, followed by anxiety disorders and depression. Verle, please.
Last years, the focus is more on tracts, and recently the focus is on selective targeting the tracts. For example, for obsessive compulsive disorder, you know the study of Madrid with provocation tests. And so the goal is to very selectively target those tracts that are responsible for the symptoms, and this is defined by provocation tests. What is your opinion about that in relation to the lesions that are rather aselective, may I say so?
Well, I think it's too early to say. I think that, yes, I think that we are on to something. And I think that in the future, it's quite probable that we will tailor the therapy to the individual patient. But that is some time away. I mean, there are few centers today that have the knowledge and the capacity to make such tailored interventions in the individual patient. So I think that we are quite a few years away, but yes, we're heading in that direction. And whether or not we should make lesions based on this or DBS, I have no opinion.
Thank you.
Bart, what is your opinion on the lesioning? Let's say ALIC lesioning versus DBS. I mean,
as far as I know, there is no randomized controlled study that compares both. But there is a quite nice overview from led by Samir Shet, published in the Journal of Neurosurgery. I think it was in 2016, where you compare cingulotomy versus capsulotomy, that's lesioning, where I agree with Patrick that capsulotomy has more side effects than the cingulotomy, but that the effect of on the Y box was better with the capsulotomy. But when you then compare that with the DBS, I think there's a publication of Pepper and Marwan Haris, and then also we have a publication on comparison with the DBS versus lesion. And in general, I can say that maybe the effect on the Y box is a bit more with the lesion than we are talking about capsulotomy, not about cingulotomy, than with DBS, but the side effects are reversible with the DBS, which is not always the case, especially the apathy that you get with lesioning. That's problematic.
But am I remembering correctly that in some cases where you have failed with DBS, you have converted the patient to a lesion?
Yes.
And has it been beneficial?
Yes, but I cannot say that these patients had their lesion exactly on the same place where the electrode was. So we cannot make a lot of conclusions from those single patients that we did.
But do you want to comment on this? Because of course, if you target ALIC and you look at your DBS results or your target nowadays, it has shifted more medially. And is it related to the extent of the lesioning? Well, that the mechanism of action is different, or the mechanism of action itself, DBS versus lesioning, I think. I mean, is the extent of the lesion with capsulotomy different from the extent of, let's say, stimulation or inhibition by your DBS? Or how do you...
I think that's a very nice thing that you say, that probably in the beginning, when we wanted to implant an electrode in patients with OCD, we mimicked the lesion. So we took an electrode which was as long as the lesion was, and we stimulated with high amplitudes to mimic the lesion as wide as it was. But of course, this is not exactly the same. So the amount of tissue, 3D, that you influence with lesioning or with DBS is very likely not the same. And probably the lesion is a bit bigger, and that may be the consequence that we have on the Y box. But Veerle, you who does a lot of research on tracts, maybe you can say more about that.
I have to say, we don't have that many lesions. We do deep brain stimulation. A couple of years ago, we performed DBS in a patient, and then we switched to a lesion because he always manipulated the wounds, scratch on them, so he had an infection. Then we had to remove everything, and then he performed a lesion. That's the only case in the last 10 years here. What the treatment of obsessive compulsive disorder is concerned.
So when you are talking about lesioning versus stimulating, wouldn't you say that the stepwise approach in an ethical sense, a medical ethical sense, would be that you try first the stimulation, even in certain conditions where you think perhaps the capsulotomy or the cingulotomy would be better, and after a certain period of stimulation, well, perhaps 1 or 2 years, and you don't see effect, then you turn to the cingulotomy or capsulotomy. Would that not be a more elegant way in a medical ethical sense?
I think
that is definitely the way. Sorry.
I think that's a very good question, but then of course we have the problem that we also have non-responders. So the question is, and then for you perhaps, Bart, if you have a non-responder, does it make sense to perform a lesion in those patients before concluding that he will not have a response of brain surgery?
Well, the way Olaf presents it was the way we presented it to the ethics committee in 1998 or 97, maybe even, that stimulation was a step in between no surgical treatment and lesioning, and that if it would not help, we could still do a lesion. In response to Veerle, the first patient we ever operated, he was helped with the stimulation only from a Y-box, which he called himself 40 plus plus plus. You know, 40 is a maximum of Y-box. He had a Y-box of 40 plus plus plus, and he evolved to 40, which was still extremely bad. And we did a capsulotomy, and then the Y-box clearly decreased. So there was a difference in that single patient, but I don't talk about a big series of patients.
Okay, but so my question to you then, second question to you, Bart, is, do you perform or do you convert toward, or do you perform a lesion in all patients who had received DBS and who do not have response? And if yes, how long do you wait then?
Okay, no, we only operated, we only turned DBS patients into capsulotomy patients in a very, very few patients. So, this is not a rule, definitely not. And if there's no responder, I mean, I had one patient who is not a responder and who came to me last week on my outpatient clinic, and she asked me to take it out.
After how, 1 year, or after how many years?
No, this was in the beginning of the 2000s that she was operated, and no, that's not true. No, I'm sorry. I think that's 7 years. This patient. Yeah. But anyway, we're talking about cases here, and not series.
Patrick, how do you see that? Do you convert non-responsive DBS patients into lesions?
No, I have decided not to make lesions for psychiatric disorders. And to be honest, I think that our results were better when we did capsulotomies than now when we're doing DBS. And it's much more work now with DBS and not as favorable results, but it's the media. When we make capsulotomies, the newspapers will write that we are performing mini lobotomies, and they will be extremely negative. When we do DBS for psychiatric disorders, then we get a very nice coverage of our work in popular media, and they say that what we are doing is really interesting and beneficial to patients. So it's so much bad publicity that I think it would keep patients away from us. So we have stopped completely with lesions for psychiatric disorders.
Do you think, that's another question, that HIFU lesions have another connotation?
I think so. I think that people do not connect this with the lobotomies. So maybe that is the future. I think also gamma knife capsulotomies are better accepted.
Psychologically, it's interesting, huh? I mean, from a psychological view, what the public is concerned about.
Oh, yeah. May I ask Bart a question? Bart, are you there?
Yes, I am.
If you suddenly woke up one morning with a terrible obsessive compulsive disorder, would you prefer to have a lesion or DBS?
Of course, I would wait at least 5 years and have other treatments.
Good answer.
Yeah, so that's evident.
Yeah.
But if I would be treatment refractory to cognitive behavioral therapy and any pharmacotherapy and suffering extremely much after having been hospitalized for many years, I would probably prefer DBS. Yeah. Because I know both, but maybe Dirk has a different idea.
I haven't a different idea, but my second question would be the DBS awake or asleep? To you, Bart.
If it would be performed to me, I would love awake, because I would like to sort of mentally help.
Help your surgeon.
Yeah, tell them where to put the electrode, you mean.
But at that time you have OCD, Bart, so that might be very difficult, you know, because now you don't have it, but at the moment of your surgery you will have OCD, so that might complicate things.
Okay, so this was the less serious part of the presentation, I suppose.
Let's go ahead. Thank you.
So, yeah, the cingulotomy introduced in the late 40s and mostly well known from the work of Ballantyne. Then we have Talleyrand, who started his career in psychiatry, but considered the brain to be too important to be left to the neurosurgeons and introduced the open capsulotomy in 49. And later Lexell introduced the stereotactic capsulotomy in 52. Concerning the results of these lesions, we have his report from 61, and in 116 patients, 50% of them were said to have a good outcome. But the results have been quite varying, both concerning the effects and the side effects. And it's likely that this is to some extent due to differences in the size of the lesions and the locations of the lesions, because most reports are obviously from the pre-MRI era, and also different locations along the whole anterior limb of the internal capsule have been used also for lesions. Then we have the tractotomy, that is perhaps of a peripheral interest, but it was developed by Jeffrey Knight, and it's the same as the subgeneral tractography later developed by Lauri Laitinen, and both of these are actually covering the most common target for depression used today, the subcingulate gyrus area 25. We also have a less common target, the amygdala, that was used for lesions starting already with Spiegel and Weiss's, but is most well known for the work of Narabayashi, who used it for aggressions. A more common target for aggressions was the hypothalamic area, and actually Walter Rudolf Hess shared the Nobel Prize with Egas Moniz in 49 for his animal experiments in the hypothalamus, and the first hypothalamotomies were performed by Spiegel and Weiss's in the same year for aggressions. And from a neurosurgical point of view, a very simplified division might be sufficient. We can divide it into 4 different areas. We have the medial or posteromedial area. This is the area between the anterior border of the red nucleus and the anterior medial to the anterior border of the red nucleus. It's used mainly for DBS in cluster headache and aggressions. And it was also here that we have also the lateral area close to the limbic part of the STN, and this is the area where the medial forebrain stimulating and where limbic STN DBS is sometimes done in depression and OCD. We have also a more unusual target, and that is the anterolateral area that was used without much success for obesity. And finally, deeper down, we have the ventromedial or anterior area that has been used for sexual deviations, anhedonia, and various quite strange indications in historical times. Anyhow, stereotactic lesional procedures was first used for psychiatric disorders, but they never became much popular. But they came to revolutionize the treatment of movement disorders, as we all know. If we take a step back, we have the first operations performed for movement disorders in 1890 by Victor Horsley. And then we have a number of later open procedures until finally the first stereotactic target in movement disorder was introduced in 47, and it was the pallidum. But it was soon overtaken by the thalamus due to its better effect on tremor. But also this led to a natural exploration of the underlying subthalamic area with discovery of a number of new targets in this area, mainly the subthalamotomy. But then came the decline of stereotactic functional neurosurgery following the introduction of L-DOPA. And not much happened from 1970 to 1991. Then we see the first step in the renaissance of stereotactic functional neurosurgery with the reintroduction of large left cells posteroventral pallidotomy in Umeå by Lauri Laitinen. And during the same era, or during the whole decades before this, we see a continuing development of the technical equipment, with first heart pacemakers that were turned into neuropacemaker in 1973 and used for pain procedures. And we have a number of pioneers who use this also for early DBS. And the beginning of the second and most important step in the renaissance of stereotactic functional neurosurgery was the introduction of modern DBS by Ben Abid in 1987. But to be honest, it was only after the introduction of a new target, the subthalamic nucleus, that the interest really started to grow, and that was in 1993. And this has been a success story, and DBS is now well established in the thalamus, the SPN, and the GPI for various movement disorders. We have more than 33 published indications, 48 targets, more than 15,000 papers on PubMed, and more than 200,000 operated patients worldwide. But the situation is similar as with lesions. DBS did not start for movement disorders. It started with psychiatric disorders. And the first case of deep brain stimulation was performed non-stereotactically in the caudate nucleus by Lawrence Poole in 1948 in this woman seen here with anorexia and depression. And later the same year, he applied the same technique to the gyre singly. Another pioneer in this field was José Delgado, who is most well known for his animal experiments, such in this video from the bullfighting arena, but who implanted also humans with psychiatric disorders as early as 1952. The first one to use externalized electrodes for testing outside of the operation theater was the Norwegian psychiatrist Carl Wilhelm Sem Jacobsen, who started in 1953. We also have the Tulane psychiatrist Robert Heath, who focused a lot on the pleasure center of the brain that he thought was between the septal area and the medial forebrain bundle and the nucleus accumbens, and implanted about 60 patients. Here we see him with one of his patients who is constantly pushing a button, self-stimulating her pleasure center. And the first one to really use chronic stimulation was Natalia Petrovna Beshtereva. From late 60s and onwards, she operated about 200 patients with OCD with externalized DBS and stimulated them for more than 1 year. And the technological development progressed, and the first one in psychiatry to use a completely implantable system, that was Gerrit Diekman in 1979 in a patient with phobias. But at that time, psychiatric procedures had become rare because of the growing opposition and other treatment options. And if we look at what has been called the psychosurgery debate, then it's important to realize that the introduction of stereotactic functional neurosurgery did not result in an abandonment of the lobotomy. It was in reality the introduction of chlorpromazine in the early 50s that meant the end of psychosurgery. And early DBS for psychiatric disorder was a rare procedure, but modern DBS for movement disorder has been a success story, and this has led to an increased interest in the potential of DBS for psychiatric conditions. And the field of psychiatric DBS has evolved mainly by the adaptation of known lesional targets DBS, but also to some extent by serendipitous findings during STN DBS for Parkinson's disease. From a purely temporal view, the first publication in this field was that of Verli. So congratulations. But since I consider Tourette to be more of a neurological disorder, I will not discuss that further, but I will instead continue with the publication of Bart from the same year in OCD. Of importance was also the later publications on non-motor side effects of DBS and STN in Parkinsonian patient, as well as the introduction of the subsinglet gyrus DBS for depression by Helen Mayberg and Rosanne in 2005. But it's not so interesting to describe this development only from a temporal perspective, so I will give a more thematic presentation. If we start with serendipitous finding during STN DBS, then we know that electrodes can twist up also were not intended, and that might be a possibility. It has been found that stimulation-induced hypomania is more common when the electrode is located anteromedial in or at the side of the STN. And in 2002, it was noted in 2 French patients with STN DBS and concomitant OCD that stimulation also improved the OCD. And this led to a French multicenter study of limbic STN DBS published in 2008. And stimulation-induced hypomania in a Parkinsonian patient with an anteromedially located electrode was in this exact same manner, more or less, analyzed also by Volker Koenen. But he interpreted the phenomenon based on tractography as caused by activation of the medial forebrain bundle, and identified this as a target, first for depression and later also for OCD. Regarding the limbic STN, positive effect was also reported from a group of Marwan Harif in London. And it's interesting to note that those stimulating the limbic STN as seen here seems, at least for my eyes, to be stimulating more or less the same area as those stimulating the medial forebrain bundle. So at least the targets are very close to each other. The report from London was a comparison between the STN and the accumbens, and most studies have been performed in the area of the accumbens, internal capsule, and bed nucleus of sclera terminalis. If we look at the area around the internal capsules, then capsulotomies were most often performed more anteriorly in the internal capsule, and DBS was first performed at the same location, but with rather limited success. When analyzing the location of these electrodes, it was noticed that the effect was better further posterior in the internal capsule, and the target was moved in this direction. And some groups, they would choose a target in nucleus accumbens, but it seems as if the effect in the accumbens itself was rather poor, and that the effect of stimulation is mostly achieved higher up on contacts located in the internal capsule. And even further posterior, in the inferior thalamic peduncle, the group of Velasco has reported good results. And between these areas, we have the bed nucleus of sclera terminalis, suggested as a target by Bart Martin, and now used also by myself. And recently, Lozano published a report on the inferior thalamic peduncle, but 2 millimeter anterior of Velasco's target. And this target must be overlapping with the bed nucleus to a large extent if one look at the location of the electrodes, and especially if we take into consideration the volume of neural activation, which is huge in this case. And considering this large volume of tissue activation, it's difficult to know what we are really stimulating and what is the best target in this area. And we are probably stimulating more or less the same, or at least connected networks at different points. So let's look more at the different indications. Concerning OCD, this is the only psychiatric indication for which lesions and DBS might be said to be established. There are a few randomized studies demonstrating that it's working, it's CE marked, it has humanitarian exemption device status according to the FDA. but there is still much that remains to be done. Up to 2% of the population has been estimated to suffer from OCD, and it has been reported that around 25% of these are therapy resistant and will not be significantly improved by pharmacological treatments or psychotherapy. And this has led to some very optimistic estimates concerning the potential number of patients who could be treated with OCD. But after 20 years or more than 20 years of DBS for OCD, there are no more than around 300 published patients with DBS for OCD. And this might suggest that this paper seen here, suggesting that the pool of potential surgical candidates is extremely small, might be closer to the truth. The reported patients are further rather heterogeneous. Since we have around 8 different targets, well, even if some of them mostly differs in name. And I will have already discussed lesions, so let's skip that. Regarding the effects of DBS for OCD, then these seems actually to be quite comparable regardless of which target that is used. And the long-term data was very nicely summarized in this recent review of 11 studies with 155 patients followed for at least 36 months. And they improved according to YBOTS with 47%. And there were three quite distinct groups. Half of the patients were responders, 1/4 partial responders, and 1/4 non-responders. And most of the improvement was seen within 1 year. And at present, we have a very limited understanding of why some patients are not responding to the treatment. And at least we have no real possibility to predict which patients that will benefit for DBS and who will not. Regarding DBS for depression, we have about 9 different targets and about 350 implanted or perhaps even 400 implanted patients. But this is an estimate on the number of implanted patients and not published, which is of course smaller. And the same targets are used here, as at least mostly as are used in DBS for OCD, with one notable exception, and that is of course the subcingulate gyrus. That was introduced by Mayberg and Lozano in 2005 based on PET studies, but it is anyhow the same area as was previously targeted in subgenual cingulotomies, as well as in the subcaudate tractotomy. Concerning the results, according to this quite old study now, 64% of the patients were responders and 43% in remission at last follow-up after 3.5 years. But unfortunately, a later multi-center randomized sham control study failed to demonstrate superiority over sham stimulation. But the results from the open phase were better with close to 50% response. And recently, Mayberg presented long-term data from 28 patients in a single center study with quite impressive results. Further, the same group have stated that in order to identify the optimal target, the gross anatomy is not enough, it's not sufficient. A retrospective connectomic analysis made of them suggested trajectography targeting based on 4 bundle convergence, forceps minor, uncinate fasciculus, cingulum, and frontostriatal fibers. And this was then performed in 11 patients, and after 1 year, 9 patients were responders and 6 in remission. This data does, of course, need to be reproduced, but at least it's very interesting. The subcingulate gyrus is the most commonly used target with about 250 implanted patients. And the second most common target is the area around the internal capsule with about 70 patients. And also here, in non-randomized studies, very promising results were presented, and then a randomized study was done and it failed. We thus have 2 failed randomized sham-controlled multi-center studies of DBS for major depressive disorder. And it is of course possible that it doesn't work, but there might be other explanations as well. The effect of DBS in psychiatric disorders does often take quite a long time to develop, and the follow-up time in these studies were limited. Perhaps less well-placed electrodes is part of the problem when involving more centers with less experience. Perhaps there were differences in programming, and there might be problems with the patient selection. There are some speculations, but we don't really know. Regarding the meal forebrain bundle, this is the third most common target for depression, and it has demonstrated in non-randomized studies fast and very good response, but less than 30 patients have been presented, and we have no randomized studies. So OCD and depression are, of course, the most common psychiatric indications, but there are a number also of other more unusual conditions. Lesional procedures and early DBS was used for addiction, among others in a large number of cases by Bechtereva. And in modern times, concomitant defects on drug addiction has been reported in several patients treated with OCD. And there has been one small case series published on DBS in the decumbents for alcoholism with rather positive results. There is one case report on successful DBS for heroin addiction, and a recent case series for the same indication, where 5 out of 8 patients had not relapsed after 3 years. But of course, these are very limited data. There has been some discussions about anorexia and obesity, I guess that there might have been added a few patients by now, but in this review, there was a total of 29 patients published for anorexia in the subsinglet gyrus and the decumbents with somewhat promising results. But this is a complex condition. Sometimes anorexia will be part of OCD, sometimes in combination with depression and so on. So there are many factors to take into consideration. And even more difficult than anorexia is, of course, obesity, where DBS in the decumbents, lateral hypothalamus, and ventromedial hypothalamus have been published in 3 reports on a total of 5 patients with very limited success. And I think that we can skip the details of these different targets for obesity. Concerning aggressions, the medial hypothalamus was, as mentioned, Sano's target for aggressions. And this target was rediscovered for DBS by the group of Francini, who reported favorable outcome in 6 out of 7 patients. And positive results have been published also in a small number of patients by others. There are further 2 case reports on DBS using the lesional target in the amygdala for autism and for post-traumatic disorders. And regarding post-traumatic stress disorder, this was actually funded with $70 million and resulted initially during the first years in only 1 published patient. I think that there is another patient published as well, and a 3rd patient published now by a 3rd group. But this is very limited, of course. So the clock is 1 minute to 6. And we have arrived at the conclusions. And I think that the important conclusion from this presentation is that there has actually been a continuous development of psychiatric neurosurgery, all the way from the lobotomy to modern DBS, even if this has been often denied due to the stigma adhering to the former procedure. Further, regarding modern psychosurgery and DBS, psychiatric disorders are a much larger cost to society than movement disorder, and there is a considerable interest in DBS to judge from reviews and similar publications. We have some promising results, but even though we've been working for 20 years or more with this, we just have a few hundred published patients, and many of these in small, unblinded, non-randomized studies, and to make it worse, in 2 failed larger randomized studies. We have numerous targets, but we don't have that much of consensus. And there are probably several reasons for this slow progress. Probably DBS is not as effective in psychiatric disorders as in movement disorders. And the patient management is much more complicated. We are still carrying the burden from the lobotomy area. But most important, to a large extent, the neurologists are responsible for the rapid development of DBS for movement disorders, not the neurosurgeons. And the psychiatrists have not embraced the possibilities of DBS, and DBS will never fly if the psychiatrists are not leading the development. So this was an attempt to a short overview of this field. And of course, I can't cover any details, but if you're interested, then you're more than welcome to the Psychiatric Academy, where we have more detailed presentations. Thank you.
Thank you, Patrick. I don't know if there's any questions.
Can I ask or say something? You talk about lesions and DBS. DBS is well started with Medtronic that gave the equipment, and in Europe this is still the only equipment that has a CE mark for that indication. However, CE marking has become more rigid, and Medtronic will not pursue the CE mark, so they will still have equipment available until August 2024, but then it's finished. So we have, and in the United States, this is not a problem because there is an HDE, which is a humanitarian device exemption, which is a solution for rare indications. And apparently DBS for OCD, you can consider that a rare indication. OCD is 1 to 2% of the population, but the ones that are a candidate for surgery is rare. So we will never get big studies running to prove that DBS really is working. I mean, big studies like the pharmacological studies and like CE marking or the notified bodies ask nowadays. So that's a problem. We have to come up with a solution there. We have to be creative.
Well, we've been thinking for 20 years, so perhaps if we just continue to think for 10 more years, we might come up with a solution.
Right, until 2024, which is, and now it's 21, so it's 3 years.
Are you sure, Bert? I thought it was 22, it's next year. Huh?
Yes, that's true, but I got an email from Medtronic this week saying that they have taken steps to still have to make enough equipment before August 2022, so that they have that on their shelves to be used later on.
Yeah, if the patient or if you found a financial source, but also the CE mark is until August 2020. Huh? But it doesn't matter. It doesn't change.
No, yeah,
so
that's right.
This CE mark, that is specifically for the electrode 3391. Is that correct?
Yeah.
And for the stimulator and for the extension cables.
Okay, for that as well.
For that indication.
Yeah.
So I think the large majority of us, at least myself, have implanted non-CE certified leads for OCD.
Yeah.
389 and or 3387. Yeah.
Yeah, I think that is much more common, but I guess it's easier to retain the IPG and connection cable and say that the therapy is CE marked, even if you change the electrode. It might be a problem if you don't have CE marked for anything.
Yeah, but nevertheless, the CE mark is until next year, and then it runs out. So the problem is not solved.
No.
Yeah. And what large studies is concerned, like you said, Bart, we will never have them. And we always have to keep in mind that we're talking about really severely affected patients, one. And second, the procedure on itself does not have a high complication rate. So we have to make the balance. And I think we have enough studies now. We have 3 randomized controlled trials what OCD is concerned with ALEC simulation. Plus we have the one from London where patients have had 4 electrodes implanted, 2 in the SCN and 2 in the ALEC, also with beneficial effect in a double-blind randomized controlled trial. So I think we have enough data. But the problem is that in total, there are not that many patients that are candidates for surgery. And that's why the companies are not interested. In contrast to, for example, dementia.
So this is a big problem. The new medical device regulation is not meant for rare indications. And while in the United States, you have the HDE, where you can have a rare disease where you develop a stimulator. You do have orphan drugs that can be given, but for stimulation devices, this does not exist in Europe. So actually we have to come up with a solution, but that's politics. That's a European problem, a European Commission problem, that this new medical device regulation has to take into account rare diseases, because it's in the disadvantage of the patients that suffer from these diseases, definitely with the evidence, as you say, Veerle, that we have at this moment.
Mark, may I ask you, do you have CE mark for performing for your radiofrequency lesions to perform capsulotomy for OCD?
So I don't need the CE mark. The CE mark is Conformité Européenne for a device, and the company who brings this on the market needs such a CE mark to bring it on the market. So I presume that these electrodes that we use for lesions, they should have a CE mark. I didn't check it myself, but
no, but specifically for OCD. This is what I really don't understand. Why can you take a radiofrequency electrode and make a lesion regardless of the indication?
I get your point.
DBS electrode.
Because that radiofrequency electrode doesn't have the same level of evidence that needs to be given by the company. The highest level of evidence needs to be given by the company if you have an active medical implant.
Okay.
Which is different from an electrode you stick in and you put out after having made a lesion. Which is logical also, and it's all in the advantage of the patient, but they forgot the advantage of the patients with rare diseases.
Yeah, Olaf, you have a question? Please go ahead.
Yes, so I heard you say, Patrick, and also the others, that there is not too much engagement of psychiatrists in the therapy the neurosurgeons could offer. So perhaps you can see a parallel in earlier years with epilepsy surgery. So the generation of older neurologists, they were afraid of brain surgery. And you saw that there was an enormous gap between the debut of the epilepsy and the epilepsy surgical treatment of the patient. And nowadays you see that this gap is still there, but it's becoming smaller. Perhaps this has to do with the system in many countries. I'm not sure, but in the Netherlands it's like this, that young neurosurgeons in training have a certain period of time in the neurosurgical department, and they see what we do. That means they are 3 months or 6 months or even 1 year at the neurosurgical department and see what kind of treatments we do. Do you think that such a proactive manner from the neurosurgical community towards the psychiatry to offer them that their residents can have a period of time inside the neurosurgical departments to see those DBS and even lesioning procedures, would that help to have more commitment from the psychiatrists?
I think it would be a splendid idea, and I think it would work if we got them to come to us, but I don't think they would come, even if we invited them. That's my feeling.
Yeah, I think that the two groups of psychiatrists, they are the ones who are open to the idea that there is a biological basis of some psychiatry. That's to start with. And, others cannot be convinced, and there you already have a bias are the ones who are not convinced at all. That they think that there's still, I think many psychiatrists think that there's not a biological basis of psychiatric indications. So that's rather psychogenic also. So I think they're really difficult to convince.
I see some questions in the Q&A and in the chat.
Yeah, I was just going to say that somebody asked if you perform DBS for psychiatric patients in the awake or sleep state.
I used to do it awake, and now I'm doing everything asleep. So I don't think that it matters much. Verle?
For ARIC simulation, we perform it in analogous sedation because then we have a better electrophysiological results. For Tourette's, both analogous sedation or general anesthesia, because even with general anesthesia, we have nice recordings because there's such an hyperactivity of the thalamus.
I explain everything to the patient and the patient chooses.
But mostly awake.
Yes.
If possible, awake, yeah.
I might have one more question. There's 2 new kits on the block. That's the directional leads and the LFP recordings, closed loop systems. Do you think there's a future for these new technologies in DBS for psychiatric disorders or not? Are there biomarkers or promising biomarkers, or is this too early?
Well, I think it's they're important tools in the direction of tailored surgery. For example, in one OCD patients after ARIC simulation, we performed sensing LFP recordings while showing the patient specific images, neutral images versus provocative images, and we saw clear changes in the LFPs. So those might help us finding the optimal stimulation parameters, but it's always in the direction of tailored stimulation. And then, yeah, we can start again with the discussion. Do we need tailored stimulation, or is a bigger lesion good enough, so to say?
I think I agree with Verle. In the direction of, we are quite far away from it, but it's interesting. It will become interesting in the future.
Yeah, for the future, we also need more studies and more patients, I assume. And with all these targets, it's getting more and more difficult. It's as if every surgeon, or every city at least, has its own target. How can we get rid of this problem? Because with medication, it's easy. There's a new drug and everybody's testing the same drug. But of course, everybody has his ideas about the brain and its intricate workings. And this is also causing problems, I assume.
Well, maybe, I don't know about when we lose the CE marking, might this be an incitement to participate in large multi-center studies? Because if it's a study, then you can use whatever you want to use. So perhaps this is a manner in which we can actually become more focused on this.
And how would you set up such a study? Because of course, yeah, movement disorders, the patient has tremor, you turn the stimulator on and you see the effect. And you see that all these open label studies have promising results, and then you do a controlled trial and it's as if nothing is happening. And of course, psychiatrists will say, yeah, but the results are negative, as a critical psychiatrist might say. And then, yeah, I don't know how to set up such a study for psychiatric disorders. Is it?
I think that what I would like to do, I can't give the whole answer, but that would be number one, to make sure that we are following the patients for long enough, that we have a group of patients that do not receive surgery for a long period. So we have perhaps not only 1 year, perhaps we should follow the operated group for 1.5 years before we make the evaluation. That is one. Number two, just to make sure that there is not a problem with misplaced electrode or anything like that. Why don't, in such a group with so few patients, do the targeting together to evaluate the patients together? Not only one center do everything and then pool the data, but more collaboration.
I think one point which was not mentioned in setting up a study is, I think that implantation is very important, but finding the right parameters is as important as the surgery itself. And so what we did in our double-blind randomized controlled trial was have a very long period to try to optimize the stimulation as good as possible. And only then, with the final best contacts, we then did a randomized crossover trial. And I think it's important to really search as good as you can for the best stimulation parameter combination.
I have two remarks what those randomized controlled trials is concerned. First, we discussed that there are many different targets. Each center has its own targets. We also discussed this aspect in congresses focused on Tourette syndrome. I think it's difficult to persuade or to convince your colleagues who have no experience with a specific target to start implanting leads over there. I think it's better that every center continues with the target he has the best experiences with, and then compare results. I would also like to remark that double-blinded trials are very difficult for psychiatric patients to convince them to switch the stimulator off or keep the stimulator switched off for 1 year. I think it's not so patient-friendly in a way. We need it for science, but I think for OCD, for example, we now have enough RCTs, I think, to say that it has a beneficial effect. So yes, those trials are important for scientific reasons and to prove an effect, but not too many, I would say. And I don't see the need of large trials with one target. That's my personal opinion at this stage for OCD.
Patrick, you raised your hand, but I don't know, it was maybe by accident. There are two more questions in the Q&A box. There is one question for a non-responder, partial responder for cingulotomy for severe OCD, via box of 40. Would you recommend to redo cingulotomy or a capsulotomy or subcaudate tractotomy? I don't know if anybody wants to answer this question.
Well, I have no real experience, so I would say that when you subcaudate tractotomies, I don't think anyone is doing them nowadays. So probably we shouldn't do that. The other option to remake this lesion, I know that with Costco will often add another pair of lesions or even a third pair of lesions in the cingulum if the first did not know. So some people are doing that. What was the third option, Tom?
That was a capsulotomy. So
well, Bart, do you have anything wise to say?
Capsulotomy, or you can have another option, maybe a better one, but
I don't have literature data. I can only say that my previous boss, Jan Gijbels, when he did the subcaudate tractotomy and there was not enough effect, he went back for subcaudate tractotomy and enlarged it. But that's not about cingulotomy and capsulotomy, I cannot say.
I know that Tipu Aziz commented on this for pain, of course, and he said, yeah, when you do a lesion and there is an effect, you can go back and make an extra lesion or another one. So he was also favoring this, of course, for refractory pain, but he said it is doable to make a second lesion, and with success, he said.
Yeah, we have done it in capsulotomies when the effect was not good. Well, actually, rather when we had an initially good effect that could be suspected to depend partly on the edema, and then it went away. Then we went back in and enlarged the lesion, and it has been helpful.
Then there's a question about experience with ultrasound MR guided lesioning. So well, it's about the focused ultrasound. I don't know if anybody has experience. Nobody, so that's an easy one. I don't know if there's any comments or questions that are burning here. Because Patrick, there is a question here, and that is from a guy who says how to become the member of a stereotactic academy. So I think that's the perfect question to go towards our final 10 minutes, where you are going to present at least how they can become a member and what the Stereotactic Academy is, and what it can offer to people, neurosurgeons, and even, well, all kinds of physical or medical specialists.
Yeah, that's a very nice question. Let me just share the screen again with you. Yes. No? Oh. So, Tom, do you see my screen?
Yes.
Thank you. So, in the interest of time, I will reduce this presentation, and just to say that there is an unmet educational need around the world. And this need is probably larger when it comes to more unusual subspecialties such as stereotactic functional neurosurgery. And I think that it might be especially large in this field and in DBS, because this differs substantially from the techniques in basic neurosurgery, if I might call it that. And further, when DBS was introduced, the targets and indications were few, and everything was quite simple. And today, we have many targets, indications, and we also see a fast development with image-guided surgery, new navigation tools, sleep surgery, directional stimulation, local field potentials, and so on. So everything is getting better and better, but also more complicated to master. And I believe that lack of proper training will explain some of the avoidable complications and poor results of DBS that is reported in the literature. And if we look at this recent large study, then 36% of those working with DBS, they have no formal training whatsoever in the field. And the remaining 64%, all but 2% has received their training from the industry. And there is also a very large heterogeneity in how this procedure is done, suggesting to me that it's not a mature technique, it's not a mature procedure, and that at some places it's not done in an optimal way. There are more than one way to skin a cat, but I don't think that there are perhaps more than 3 or 4 ways to do DBS. If you have 10 different or 15 different ways, then not all of them can be equally good. So today we get our training by finding a good mentor and spending some years with him. That's the best way. We can go and visit someone for a few days, but at least those that are visiting me mostly see my back, so I don't think they learn a lot. We can consult the literature, but that does not tell you how to do things. It's too scientific. And we can, of course, go to a course, and courses are very nice, but of limited availability. And for that reason, we have created the Stereotactic Academy at stereotactic.org. This is an educational resource under the auspices of the WSSFN. It was put online in the beginning of 2018, and we have now more than 1,500 registered users. It is an e-learning resource intended to be a complement to the traditional methods of learning. And it's focused on providing clinical knowledge, how to do DBS and stereotactic procedures in general. All material is completely free, it's easy accessible, and requires only an internet connection. And our goal is to provide a more extensive material than can be fitted into normal courses, and to reach colleagues around the world with limited access to our traditional educational tools. The most important part is the encyclopedia. It's a collection of lectures organized in a very structured manner, guiding the user through every aspect of the procedure in a logic and stepwise manner. And we have currently more than 170 lectures, and the number is increasing. And we try to work as much as possible with images for pedagogic reasons. Many of the core lectures are based on our experience in Umeå and London, to provide a more straightforward philosophy without contradiction. But more importantly, we can rely on 70 skilled experts who are sharing their knowledge and providing alternative techniques and a wider perspective. Many of the lectures in the encyclopedia are then combined with other material into courses, of which we now have more than 20, such as targeting stereotactic function, neurosurgery, calculation of coordinates, and so on. And we have now started to apply for CME accreditation. Just to show you one example, we have, together with a number of residents and experts in neurosurgery, created a course that will cover what we consider that everyone should know after completing a residency in neurosurgery. And this is not intended for those who want to pursue a career within the field, but for those who need a general introduction as a part of the residency. This course consists of 22 lectures. It's divided into 4 parts, and we start with historical background and current trends within the field. In the next part, we will look at targeting at a basic level, how to do calculations, how to use a navigation system, how to identify the most common targets in an easy manner. And we're also providing downloadable cases where the student can do the targeting according to the instructions in the lectures and then compare with our suggestions. And the next part deals with surgery. In the first 3 lectures, we'll look at how to assemble, prepare, and mount a stereotactic system, and we are covering a number of different systems. We then continue with DBS implantation, or how to make a radiofrequency lesion or a stereotactic biopsy. In the final part, we will look at indication and results. And if the student is not satisfied, then they can move on to the 20 more advanced courses that will explain everything in more detail. We also have a community with a newsletter that has been much appreciated, and we spend a lot of time on social media, and this enables us to reach young colleagues around the world that are not well integrated into our stereotactic community. And for the same reason, we're also translating the material to other languages, into Japanese, Chinese, and Spanish. So if you have the time, please have a look around at the Stereotactic Academy and see if you can find anything of interest. Thank you.
Yeah, thanks so much
that's
for
the
this.
Stereotactic Academy.
Sorry?
So that's the Stereotactic Academy.
So how can he or she enroll? Just enroll.
Just go to the webpage at stereotactic.org, and then when you try to log in, it will tell you you need to register. So you just register, and within 24 hours, you have complete access to everything completely free.
Thanks so much. It's a fantastic initiative. And I think it's really a treasure of information, and definitely worth checking out. I think we can wrap up soon. So to conclude, I think we can be cautiously optimistic, if that's correct, about the role of neurosurgery for psychiatric disorders. I want to thank you for all the effort you put into this presentation. Thanks for sharing this. And I want to thank everyone for the very wide discussion we had. It was a really enjoyable conversation, also very dense. And thanks everyone for joining the session. And until next time, I would say.
I also would like Tom, yourself, for moderating the second webinar of our functional section. Very well done.
My pleasure and a pleasure. Thank you.
Thank you. And also Patrick and all the other contributors of this second webinar. Well, it was well done, well presented, very nice and good content. And it's good to say perhaps that all those webinars are recorded and will be archived in the Academy portal of the EANS. So that means that all individual members of the EANS can look back to this webinar and the other webinars in the Academy portal of the EANS.
Thank you all.